So what do we mean by ecodynamic? What do I mean by using an ecodynamic approach to shock? All of you here are hopefully familiar with the Rush protocol. It was actually defined and first published by Scott Weingart, Brett Nelson, and Phil Andrews from here. And now is, I would say, the standard of care for emergency physicians assessing patients with hemodynamic instability anywhere. But that protocol is really a tool to help us assess and differentiate between the four main categories, try to stratify patients between the main syndromes. But sometimes we need to go a little bit further. We need to dive a little bit deeper. We need to get some actual data. We can use echo, point of care echo, the same tool that you are able to deploy on your daily practice as a hemodynamic monitor. These are examples of patients, these are clips of a patient that is representative of something that you see often. This patient is clearly in shock, right? You have your eyeball, and according to the literature, our eyeball is pretty good at recognizing and identifying what is the cardiac function, specifically the left ventricular function in that patient. And even if I ask a random intern here, I'm sure an intern is going to be, yeah, that's probably EF of 10% clear, maybe less, 5%. But there's more information here, and there's many scenarios in which I want to know actually more. When I started doing this, I would miss some things that now, having a little bit more training and more knowledge, I actually can take advantage of. For instance, in this patient here, it's clearly that there's a decreased EF, but that left atrium, that is not normal. That is a massive left atrium. It's probably 6 centimeters. So that tells me that patient has probably long-standing severe diastolic dysfunction. What does that matter? That is critical to answer the question of how much fluids I'm going to give to this patient. As you find out, with some of the tools that we're going to use in this approach, we can actually take into account that. So take into account that structural assessment of the heart and then put it together with some functional assessment. So what we want to do with echo is go beyond just assessing how does a heart look. Is a heart small, big? Is the RV small or big? We want to actually put some numbers. We're going to assess the cardiac function. I love video. I'm an amateur filmmaker, and I love video because video and film is an exceptional medium to tell stories. And what we can do with echo in our critically ill patients is to tell a story. That will help us better understand what's going on throughout the stay of our patient, and even more, a story that can be helpful for those taking care of our patient in the next 12 hours or days coming upstairs. So not just a snapshot, a one-time assessment, but an actual probably minute-to-minute or hour-to-hour assessment of the patient's hemodynamics. Why? Why are you doing this more complicated, you might ask, right? I already have my Rush. It takes me 1 minute, get all the views, high them up. Remember that it's almost like a spinal reflex. They walk in, they're hypertensive, I do a Rush. I got it down. Why would you make things more complicated? Fundamentally, ejection fraction, which is what we're assessing in the majority of cases, is just not a good marker of LV function. So this distinction between ejection fraction and stroke volume is one that you really need to understand when you take care of critically ill patients. There's many situations in which a patient with a normal or high ejection fraction, as assessed by your eyeball, will have actually very low stroke volume and therefore low cardiac output. And that is important to know. There's many scenarios. A hypertrophic cardiomyopathy will have a normal ejection fraction, but actually low stroke volume and cardiac output due to a very small left ventricular end diastolic volume. So there's just not space for more. RV failure, another classic. It doesn't matter how hard your LV is working. If the RV is not pumping in, there's just nothing to work with. Hypovolemia, classic. It's a common pitfall among novices. When we assess a patient that looks like it's especially tachycardic and is hyperdynamic in the setting of hypovolemia, very often that patient is actually not producing any meaningful cardiac output. And in general, cardiac output states low cardiac output states will have normal and sometimes high ejection fraction. So we want to move from this just primarily quantitative to a from a qualitative to a quantitative assessment. And for that, we're going to need a couple of new tools. So how are we going to do this? You need a couple of, and I say new between parentheses because many of the concepts you are hopefully familiar with. But we do need to make sure that you understand these concepts in order to apply this information appropriately. These are all functions that exist within your machine and your equipment right now. So Doppler. We want to understand one principle, which is Doppler is measuring frequency shift, specifically of the RBCs. So we're assessing differences in velocities of those RBCs. And there's one critical thing to really understand if you want to use Doppler, and that is because of a complex mathematical equation, you really want to ideally be standing with your beam parallel to the flow in which you're measuring. This is a very, very common mistake. We only have about 15 degrees of tolerance. Beyond that, we will be really underestimating that shift and therefore any velocities that we're attempting to measure. So it's important that you don't proceed with making measurements using Doppler unless you are close to parallel to your flow, ideally under 15. Pulse width Doppler. As the name indicates, the machine is delivering pulses. So it's intermittently sending a pulse and sensing, listening only for a small fraction of the whole period. The Doppler interrogation in this case is happening at a very specific depth. This is what allows us to interrogate a very specific fraction, for instance, the gate located right in front of the mitral valve inflow. And obtain information about the velocities of the blood at that point. That is different from continuous wave Doppler, which is essentially interrogation throughout the entire length of the ultrasound beam. So pulse wave Doppler is the tool that you want to be using for these measurements. The last one is tissue Doppler. And this one, tissue Doppler, or TDI, is probably the one that maybe at least only a few of you here are familiar with. Tissue Doppler is essentially, instead of assessing the velocity of the RBCs, is assessing the velocity, the displacement of the myocardial tissue. That is going to be helpful for the part where we want to assess the response of the ventricle and the atrium, specifically the annulus of the mitral valve, to volume as a way to assess essentially diastolic function. So going back to the basics, from the hemodynamic standpoint, the problem is we want to generate an optimized cardiac output. And for that, we have a preload, a stroke volume that we want to optimize, and we have an afterload. And that actually ultimately will generate, and the goal should really be optimized tissue perfusion, right? Intensivists that often really making the distinction between pressure and flow is really not the same. Echo can help us with the micro-height hemodynamics and figuring out what is that optimal flow. Tissue perfusion is what makes the difference between an angry intensivist and a happy intensivist. So, echo-guided micro-hemodynamic management. We're going to ask a few questions. How is the LV function? Not just the ejection fraction, but what is the actual stroke volume? Can fluids improve the stroke volume of our patient? Is the LV actually able to take more fluids? Are the valves, specifically the mitral valve and the aortic valve, competent to carry on with this task? And are the heart rate and the SVR, the tone of the arterial vasculature, actually optimal? And the elements that we're going to use to assess that are contained here. You'll see I don't have a mnemonic like HIMAP or anything like that, and that's on purpose. I think this is something that you're not going to learn. You're not going to walk out today knowing how to do this. What I want to do today is to introduce a concept, and I want to inspire you to go back to your patients and start applying this, start building this additional skill set to be able to do this. This will require some understanding and integration of some, if you will, more advanced physiologic concepts that we don't often maybe think about. So stroke volume and cardiac output We want to assess IVC or the SVC if we're using TEE, essentially to have an idea of what the irradiator pressures are. We want to have a sense of what are the left atrial and left ventricular filling pressures. This is often, I think, a point that is missed and underutilized. And as I will point out, I think it's a critical importance when we're trying to determine if a heart can actually take more fluids. We want to assess TAPSE as I think the most generalizable and easy to achieve assessment, functional assessment of the RV. And finally, we're going to actually do a qualitative assessment of the valves that, as you'll see, is fairly simple. We're going to end by assessing the SVR, basically simply integrating a formula. So stroke volume, this is the meat here. What you need to understand to be able to calculate and estimate stroke volume is essentially that stroke volume can be estimated by knowing the cross-sectional area at the left ventricular outflow tract times the VTI. And what is this VTI of the left ventricular outflow tract? Essentially, if you think about this, if we know the diameter and therefore the radius of that hole, the left ventricular outflow tract, and then we know the height of the column, that is essentially our stroke volume. And so conceptually, the VTI, or velocity time integral, is the height of that column of blood that is exiting the heart every single beat. So how are we going to do this? In order to do this, we want to first assess and determine the diameter of the LVOT. In order to do that, we're going to go to our Parsonal long axis view, and we're going to do two things. I want to give you two pearls because this is critical for when you start actually doing this so that you get the numbers right. First, you want to place the calipers right in the correct angle. And a very often common mistake here is that you place the calipers in the vertical position, but the calipers should be following the vector in which that LVOT is directed. So green line is the right position for that. Second, zoom in. Always make this measurement zoomed in order to get an accurate measurement. Why is this important? Because when you put this in a formula, this will be square. So this is the most important source of error when you calculate cardiac output using ultrasound. You're going to get your 4-chamber view, you're going to tilt your probe, and you're going to get that 5-chamber view. You're going to bring into the picture that LVOT. Once you do that, you're going to add color. And I like to do this so that I know where the jet is. You're going to simply put your color, put the gate right over the LVOT, and it's that blue sausage there. That is our LVOT, basically column of blood. And you're going to place your gate right in the middle of that column, at the center of the LVOT. And with that, you're going to get these beautiful envelopes, which you want them to be nice, sharp, and hollow. And that will tell you that you're standing in the center of a laminar flow that will make your measurement accurate. You're then going to manually trace that waveform as done here. Ideally, you want to do at least 3 so that you get an average and that is more accurate because there's some beat-to-beat variation and that will be great, even more enhanced in patients with arrhythmias. So this is an example. This is a patient that we thought had septic shock, 56-year-old gentleman who was hypotensive. This is the VTI of 4.58 centimeters. As a general rule, a VTI under 17 is abnormal. When you get a VTI between 17, 18, and 20, that's generally speaking a normal VTI for a 70-kilo person. So this is clearly not normal. So when we put into our formula, we know that the LVOT diameter is 2.65 centimeters. And with that, plugging in the numbers, we can get our stroke volume. 2.5 liters per minute. You don't have to be an intensivist to know that that is not really a good cardiac output. And so what we learned when we did this formal assessment is that this patient really didn't just have pure distributive shock. This patient had mixed and overlapping syndrome with a cardiogenic component of something that has been well defined and described, which is sepsis-induced myocardial dysfunction. So there's a cardiogenic component here. And you actually don't have to do all this math in your head. You can actually go online and just put all the numbers, and formula will spit out your cardiac output. There's all sort of apps, and even your ultrasound machine will actually do this for you if you know how to operate the package. So once you measure the LVOT diameter, you can stick to that number. That's not going to change in your patient. And then you just do serial VTI measurements throughout the rest of your shift, throughout the rest of the period that you're dealing with this patient. That VTI basically will become a factor, a marker of cardiac output that you can trace and assess with assess the response to your interventions. So we've assessed and identified the actual stroke volume in our patient. We have a more objective and real numbers to go by. Number two, we want to assess whether the patient is actually fluid responsive. And I'd like to talk about actual fluid tolerance. And Chad Myers is actually going to go deep and take a more comprehensive dive into this. As you know, there's a lot of literature, and we could spend a whole day discussing fluid responsiveness, especially IVC assessment. What I want to mention here as part of the assessment and part of the points that I make to my fellows and my residents constantly is that the concept of IVC assessment in respiratory variation is essentially just an idea, as a marker, a surrogate of right atrial pressure. We're basically getting a window to the right atrial pressures. And there's plenty of evidence documenting that IVC size correlates with right atrial pressures. You're not interested in that. The IVC diameter is what's considered a static hemodynamic parameter. You want to have dynamic hemodynamic parameters. So a dynamic version here would be variability of that IVC diameter with inspiration with ventilations, either in a spontaneously breathing patient or mechanically breathing patient. So that's an important point to remember. IVC is essentially giving us an idea of the CVP and therefore the right atrial pressures. When you make this assessment, when we make a measurement of the IVC, it's important to not make this mistake. I was trained doing this assessment in a longitudinal axis because it looks nice. You can see the change, especially in the M mode. But it's very common that you lose you get off plane with the inspiration movement, and that will basically set you up for failure, will give you a false measurement. Therefore, I recommend to stick to 2D and do this in a transverse view. As you can see there, there is basically the long axis view of the IVC is going in and out of plane, and therefore you're getting a false reading that might look at first glance as a responsive collapsible IVC. I want to make very clear the volume, that assessment of the IVC tells us something about volume responsiveness, but not about volume status. We hear people all the time say, I'm going to assess patient's volume with ultrasound. We're not doing that. We're not assessing the patient's volume. We're assessing their ability to actually take that volume. Normal volemic patients can be volume responsive, and therefore it's important to keep that point in mind. These are images of a patient in kind of a different states. On the left, a collapsing IVC. On the right, a more plethoric IVC. Again, it's important to be careful with those measurements in longitudinal axis with M mode. If you don't have an IVC available, which is, we know that in roughly 20% of critically ill patients, we can assess the IVC. We are fortunate both here and Penn to have transesophageal echo. So in a mechanically ventilated patient, an intubated patient, you can use the SVC as a surrogate of that fluid, as a factor to assess fluid responsiveness. This has been validated in the ICU setting. Villaveron in Paris demonstrated over a variation of over 36% separated responders and non-responders as the best cutoff. So you can do that either with M-mode or simply 2D with a bicaval view using TE, and I'm sure, cover that in other lectures. So what can the IVC or the SVC tell us with ultrasound? Does this patient need fluids? Does this patient respond to fluids? Can this patient actually tolerate a fluid bolus? Well, the answer to the first question is nope. Can't really tell us anything about the need of fluids. Will this patient respond to fluids? Yeah, there's a fair amount of data demonstrated that we can separate responders from non-responders. Can this patient tolerate the fluid bolus? Yes, but we need to know a couple more things to know at what expense will that patient be able to actually increase his or her stroke volume with that fluid challenge. So is this fluid responsive patient actually tolerant? And this is what we're going to try to add a little bit more information to answer this question more appropriately. So the left atrial and left ventricular filling pressures are the key here. Every time we give a fluid bolus, that will have an impact in the left ventricular filling pressures and the left atrial pressures, or ALAP. By definition, the heart's ability to accept that fluid bolus without going to abnormal levels of pressures in those two pressures is what defines a normal diastolic function. So by doing this, we're essentially assessing, screening for diastolic performance, which again is critical in order to know whether the heart is actually going to tolerate the fluids that we give. The first element in that assessment is simply look at the size of the left atrium. Those are the numbers that you hopefully can remember or look up when you're making this measurement. But if you meet your patient for the first time and the left atrium is more than that, that probably tells you that patient has long-standing diastolic heart failure, and you should consider that in your resuscitation strategy. But there's a couple of functional, dynamic parameters that we can actually assess. Using pulse wave Doppler through the mitral valve inflow, we can assess the E and A waves. And this might sound complicated, but it's actually pretty straightforward. Putting that gate right at the tip of the leaflets in the mitral valve in an apical 4-chamber view, we're going to get a plot that looks like this with two waves from our pulse wave Doppler. The E wave tells us basically the ability, it's a reflect of the heart of the left ventricle ability to relax, and the A wave is essentially a marker of the interaction between the left atrial contraction and the LV compliance. So that's the E wave and that's the A wave. That's how they normally look. A wave is smaller. I'm not going to get into all the details of how you actually assess diastolic function, but as a screening in your critical ill patient, if you get an E to A ratio of more than 2, you know that you're dealing with severe diastolic dysfunction, and that, again, you should consider being careful with how much fluids you're going to give to that patient in that particular situation. So we're going to develop our 4-chamber. We're going to put our collar again to find that nice sweet spot where we're going to then place our gate right at the tip of the leaflets at 2 to 3 millimeter pulse wave Doppler gate, and we're going to obtain our peak velocities. We're going to measure manually those velocities, and the machine is going to spit out actually that ratio for us. Again, most ultrasound machines with a cardiac package will actually have this readily available for you to do it automated. Second, we're going to go one step further and use tissue Doppler to assess the mitral annulus. And this is the second part of the diastolic assessment. How we do that, we're going to simply put our Doppler gate in the pulse wave again, right at the lateral annulus, right next to the mitral valve. And we're going to obtain a tracing that looks like this. This, in the bottom, is what we're interested in. The E prime wave is essentially a marker of diastolic dysfunction. So we're going to do that assessment on the lateral wall and on the septal wall in both sides. So we're going to have an E prime from the lateral annulus and for the septal annulus. And we're going to average those and have an E prime that will be by itself another marker of diastolic performance. This is how this looks when you press the TDI in your machine, And then we're going to add the gate. We're going to obtain this case of the lateral. This is the case of the sept, of the medial. Again, most machines will actually integrate those numbers and spit out an average for you. And the number that you want to remember here is 14. An E prime ratio of over 14 has been validated as a good predictor, as a reliable predictor of pulmonary artery occlusion pressures, or wedge pressures, if you will, over 18. Why is that important? Because, again, that is a marker that that patient's left heart is probably not going to have the ability to take much of the fluids, even if you give them. So why is this also clinically relevant beyond just understanding a little bit more of the patient's physiology? I'll give you one example with this case here. The A wave, as you saw before, is normally a small little wave. When you see predominance of that A wave, what that tells you is that that patient has a bigger contribution of that atrial kick. Why is that important? We often have patients that are critically ill, that are hemodynamically unstable, that have atrial fibrillation. When you see this and you have a patient that is paroxysmally going in and out of AFib, you should consider maybe keeping that patient in sinus rhythm to optimize the stroke volume, because you know that that patient is really dependent on that atrial kick. And you can assess that easily with ultrasound. So we've done an assessment of the patient's ability to receive and take and tolerate fluids. We're now going to screen that right ventricle. I'm going to go really quickly through this because I hope that most of you have already done this. We have a validated tool, CAPSI, tricuspid annular plane systolic excursion, essentially using the principle that the right ventricle moves in a vertical axis mostly. That's the main sort of axis of performance. Therefore, assessing how much displacement that vertical axis is occurring at the tricuspid annulus is a good, reliable predictor of that RV performance. And putting this into M mode will give us a number, and we know that under 1.7 centimeters or 1.9, as other guidelines say, is highly predictive of RV dysfunction. So you want to do that quickly to assess whether your patient is like this patient with severe RV dysfunction. Why is that important? Because that will be important to consider during your resuscitation strategy, during your plan for intubation, and many other things. One thing that is often forgotten is that commonly in patients with RV dysfunction, they will have TR. TR is a common both acute and chronic event happening in the setting of RV dysfunction. So screen for that, put color on that tricuspid valve. And that is a good segue to the last formal component of this assessment, which is to look at the valves. Have a quick glance at the performance of the valves that you need in order for your heart to have a proper stroke volume. So what we're really doing here is assessing for clinically significant valvular pathology. And you might say, well, valvular pathology is beyond the scope of emergency physicians. Sure, it's true. But if you put simply color and understand the basics of Doppler, you will pick up severe and clinically significant valvular abnormalities. This is really all you need to know in order to identify valvular abnormalities. You need to understand Doppler. And in order to that, remember this guy. Yellow top, red at the center, blue at the bottom. Blue is away, red towards the probe. That's basically guiding you on how to interpret this color mapping. And the yellow is aliasing. And we really care about mostly the mitral valve and the aortic valve. So I'm going to give you one example just to prove this concept. This patient that our team had, we're looking at this, and everything looked fine, right? But the patient was really hemodynamically unstable. And there was a very good reason that we were able to see once we put color on that valve. So you don't need to be a cardiologist to see this massive jet here. So that's aortic regurg, and that is easy to be picked up just with some color. And again, not really visible without a color over that valve. Aortic stenosis, another simple example. We're seeing yellow through really poorly opening of that aortic valve. So that yellow is aliasing high velocities through a stenotic aortic valve. Again, that in that case was also the culprit of a hemodynamic instability and sort of disarray in that one patient. So again, the point here, put color on your valves and see if things are looking how they look. The last piece, now that you have the stroke volume, you have that number, you can integrate those numbers into a formula and actually have a decent idea of what your systemic vascular resistance is. Once we enter that in that formula, we can have an estimate of the systolic vascular resistance, which we use, the systemic vascular resistance, which we use as a broad marker of how, again, good or bad the peripheral tone of that patient is. So we can take that into consideration in that decision to either go up on the pressors, go or stay where we are with the pressors, go up on the fluids, maybe choose ionotropic support as opposed to just peripheral vasoconstriction. And that is pretty much what you need. So I want you to go and work on these elements. I want you to try to assess stroke volume in your next critical patient. Try to assess that responsiveness using the IVC. Try to assess that LV and LA filling pressures to have a better idea of what's the diastolic function of the patient. Try to assess formally the RV function in your next patient, and just please put color on those valves. If you're wondering whether there's actual data for this, there's plenty of data, and there's actually in 2015 the American Society of Echo published guidelines basically guiding the use of point-of-care echo for hemodynamic monitoring. If you're interested, you should read these guidelines. There's all sort of standard values and how-to and competency requirements. And with that, I thank you for your attention and take any questions you have.